Why is the exact same life-saving medication sold for dramatically less money overseas than it is right here in the United States? It's probably the single most frustrating question in American healthcare, wouldn't you say? And right now, the policy world is just erupting with proposals trying to finally change that.
That's absolutely right. And the battle lines, well, they've really been drawn around two completely opposing strategies for trying to lower these drug costs.
Okay.
On one side, you've got this government mandate approach. It's largely centered on what they call the most favored nation, or MFN pricing policy.
MFN, right?
Yeah. The core idea there is pretty simple.
Yeah.
If foreign governments are mandating lower prices,
Right.
well, maybe we should just import those price controls and pay less too.
Okay, so sort of piggybacking on what other countries are doing. And what makes this deep dive so timely, I think, is the huge movement we've seen recently on, well, both sides of this issue.
Exactly.
The White House recently announced a really significant agreement with Pfizer. They actually committed to selling nearly all their medications to Medicaid at that MFN price. And maybe even more striking, Pfizer is offering these huge immediate discounts. We're talking like 50% to 100% off on some really popular drugs for all consumers.
Which is massive. And crucially, this action came right alongside the development of the TrumpRx direct-to-consumer website,
okay.
which is really the perfect tool for making those deeply discounted prices transparent and, easily accessible to pretty much anyone.
So we're faced with these two radically different reform tactics happening almost at the same time. You've got MFN relying on government mandates and foreign price controls.
Right.
And then you have this direct-to-consumer model, which sounds like it's all about market transparency and cutting out the middlemen.
That's the idea.
So our mission in this deep dive is really to unpack the risks, maybe inherent in that mandated approach versus the potential rewards of a market transparency solution. We want to focus on how both paths impact innovation, access, and whether the American taxpayer is finally getting a fair deal.
And to really understand these potential solutions, we have to grasp the scale of the problem first. You mentioned the price disparity. And the sources we looked at highlight just how stark it is.
Yeah.
On average, Americans pay almost 3 times more for the same exact medicines as people in other developed countries.
3 times. Wow.
Yeah. And if you zoom out a bit, the data shows U.S. drug costs average 4.22 times more than in 33 other OECD nations.
Okay, that isn't just a small difference. That's systemic. And it kind of explains why that whole global freeloading argument hits so hard, doesn't it?
It really does. Critics of the current system, they claim that these high U.S. prices are unfairly subsidizing basically all global drug research and development. We're, in effect, footing this enormous R&D bill for the rest of the world.
So we pay more so others can pay less, essentially.
That's the core of the argument. I mean, think about this statistic. The U.S. accounts for roughly 75% of global pharmaceutical profits.
75%.
Yep. Yet we only have less than 5% of the world's population. Foreign governments, they often use these aggressive mandated price controls to get drugs, dirt cheap.
Right.
Which means the American consumer and the American taxpayer end up shouldering the cost of innovation that ultimately benefits everyone else too.
And if anyone tries to suggest that this huge disparity is just, the free market working, well, our sources are pretty clear on that. They say the U.S. market is, and I'm quoting here, unequivocally lacking free market dynamics.
It's broken by design, is the argument.
How so?
Well, that's the key context, right?
Yeah.
The market is fundamentally distorted. For one thing, most Americans rely on third-party payers, insurers, employers, the government.
Okay.
Which totally obscures the true cost of the medicine for the actual patient. You don't really see the full price tag.
Right. You just see your copay or deductible.
Exactly. But the biggest factor, according to these sources, is that Medicare and Medicaid are legally required to pay for nearly all FDA-approved drugs. In a functional free market, right? The buyer can walk away if the price is too high. They have negotiating power. But since the U.S. government must pay, well, pharmaceutical companies have a huge incentive to charge exorbitant prices because there's very little pushback.
No leverage. Okay, that makes sense. And this brings us then to the critique of these government mandates, like MFN. When policymakers propose something like MFN, it's viewed by, many conservative groups, like the National Taxpayers Union, for example, as a pretty dangerous step towards more centralized government control.
Right. And what's fascinating here is how these policies get framed. Sources that focus on market principles, they critique MFN policies as being essentially Implicit price controls.
Implicit price controls.
Yeah, because they rely directly on mandate systems used by foreign governments.
Yep.
The core argument here is kind of philosophical. When the government mandates prices below the, let's say, true cost of production or research, you inevitably introduce what economists call a deadweight cost on society.
A deadweight cost,
Yeah.
meaning...
Meaning a cost that doesn't just show up as dollars and cents. It manifests in other ways, non-monetary ways.
Okay. And the most immediate, maybe the most terrifying manifestation of that deadweight cost is the fear that these price controls will, quote, kneecap new drug R&D.
Exactly.
And we're not just talking about, like, slightly slower progress. We're talking about potential cures being delayed or entirely undeveloped. This concern isn't just theory either, is it? It's been quantified by government economists.
Yeah, we have to look at the official projections that were based on similar legislative attempts in the past. The Council of Economic Advisors, the CEA. They estimated, for instance, that imposing broad price controls could result in up to 100 fewer drugs entering the U.S. market over just a decade.
100 fewer drugs. That's significant.
That is. And looking specifically at the price control mechanisms in the Inflation Reduction Act, the IRA, economists estimated that R&D spending could be reduced by really a staggering number, $663 billion through 2039.
Wow.
And that this could result in 135 fewer drugs being approved.
Those are huge figures,
Yeah.
and they're often cited by industry and free market groups. Are there sources that push back on those estimates or suggest maybe those economic models are too pessimistic about the impact?
Oh, absolutely. There are opposing views, of course.
Yeah.
They usually argue that the industry tends to inflate its R&D costs or that the link isn't so direct. But the conservative source material we're looking at for this deep dive really emphasizes that the risk of stifling innovation is real, it's quantifiable, and it could be permanent.
Okay.
And if we accept those potential risks to future innovation, we also have to look at the immediate risk to patient access.
Right. Which raises a really important question, I think. If the government projects these huge taxpayer savings from a policy like MFN, is that money actually saved because prices genuinely dropped? Or is it saved because people simply stopped getting the medicine they need?
That is a critical policy dilemma, absolutely. And the Centers for Medicare and Medicaid Services, CMS, they actually acknowledged this concern publicly.
They did.
Yes. They projected that some of the taxpayer savings from the MFN model might be partly due to, and this is their phrasing, beneficiaries not accessing their drugs or seniors foregoing care.
Foregoing care, that's stark.
It is. They estimated that up to 1 in 5 beneficiaries, 1 in 5 who would normally have access to MFN drugs, would not actually access them under the model. That presents a really significant policy trade-off, right? Saving money potentially by reducing care.
Yeah, that's a tough equation. And then you have the unintended consequences aspect too. When you artificially restrict prices on some products, manufacturers might respond by raising prices on their other drugs, the ones not subject to the controls.
Exactly. That's cost shifting. We also see the impact potentially in supply stability, especially when you look at generic drugs.
So,
Well, intense competitive pressure, often driven by things like price controls, leads to razor-thin profit margins for generic manufacturers. And when those margins are so tight, manufacturers have basically zero incentive to invest in things like production quality, facility upgrades, things that are essential to prevent contamination or production failures.
which could lead to
Shortages. This directly contributes to drug shortages, which, by the way, recently hit a record high, 323 active shortages in the first quarter of 2024.
Wow, 323. Okay, so let me recap the argument against price controls. They risk future innovation, they might limit current patient access, and they can destabilize the supply chain, potentially leading to shortages. It sounds like MFN focuses entirely on the price the drug manufacturer sets,
Right.
but maybe ignores this massive financial leak somewhere in the middle of the system.
That is the perfect transition, because that brings us to the alternative, the market-driven solution. Cutting out the middleman via the direct-to-consumer or DTC model, the one championed by TrumpRx.
Okay, the middleman.
Yeah. The real power brokers, the gatekeepers, if you will, in the current system, are these entities called pharmacy benefit managers, or PBMs.
PBMs.
Right. And the market control they have is just staggering, isn't it?
It's enormous. Just 3 companies, CVS Caremark, Express Scripts, and OptumRx. They control about 80% of all prescriptions dispensed in the U.S.
80% from 3 companies.
Yeah. They act as these, opaque financial funnels, for a massive amount of money.
And that funnel is bleeding the system dry, according to these sources.
That's the claim. Sources note that roughly half of all U.S. drug spending currently flows back to PBMs and other middlemen.
Half. Not to the drug makers or the patients.
Not to the companies developing the medicines or treating the patients, no. It goes to the middlemen. PBMs extract these enormous, often secret, discounts, rebates, and fees. They actively exploit a total lack of price transparency to, as one source put it, essentially gouge patients and employers alike.
So the argument here is the core problem isn't just the initial price the manufacturer sets, but where nearly half of that money leaks out before the patient ever even sees the drug.
Precisely. And this is where the DTC model comes in as a potential, free market solution.
The main benefit is actually pretty simple. It allows pharmaceutical companies and patients to cut PBMs and other middlemen completely out of the picture.
Just bypass them entirely.
Exactly. By bypassing these gatekeepers, the DTC model forces transparency. Patients can potentially buy medicines at fair, transparent prices directly from the manufacturer or through platforms like TrumpRx that facilitate that.
And this shift, presumably, does more than just save money.
Oh, absolutely. It could radically simplify access. Imagine sparing patients the frustration of, PBM coverage restrictions, claims denials, all those agonizing prior authorization requirements.
Which, let's be honest, PBMs often use, not necessarily for the patient's benefit, right? But maybe to steer patients toward drugs that offer the largest rebates for the PBMs themselves.
That's a common criticism, yes. And for an employer or an insurance plan, cutting out those massive PBM fees, well, theoretically, that should lead to reduced premiums over time.
So it could be a win for the patient, the employer, maybe even the taxpayer, because it relies on transparency and choice instead of government mandates.
That's the argument. If we connect this back to the bigger picture, the fundamental policy tension becomes really clear, doesn't it?
Yeah.
Do we try to solve the high price problem through government mandates like MFN, which critics argue risk innovation and access? Or do we go through market transparency, like the DTC model, which attacks the middlemen who seem to be absorbing nearly half of all drug spending?
And the policy debate, particularly from a conservative or free market viewpoint, seems to overwhelmingly favor that market-based solution.
That's generally true, based on the sources emphasizing market principles.
And what really stands out to me here is the broad appeal this market approach seems to have, this DTC model, promoting transparency and choice. It actually enjoys pretty wide bipartisan support, right?
That's what recent polling suggests. One poll showed 86% of all likely voters, and that includes Republicans, Independents, and Democrats, support the idea of drug makers bypassing middlemen and selling directly to patients.
86%. That's huge bipartisan agreement in today's world.
It really is.
Yeah.
It suggests that, regardless of political affiliation, many Americans recognize that the system feels broken and that the opacity created by these middlemen is a major point of frustration and potentially financial drain.
Okay, so here's a final provocative thought for you, our listener, to maybe chew on after this deep dive. If direct-to-consumer sales, like the ones potentially facilitated by platforms like TrumpRx, actually achieve truly transparent and heavily discounted pricing, will the pharmaceutical companies decide that the, roughly $70 billion annual profit stream they currently seem to forfeit to PBMs, is that simply too valuable to ignore? Could this fundamentally reshape the entire drug supply chain and maybe, just maybe, finally dismantle the PBM monopoly?